and the options what we have in this scenario. So since this is a heterogeneous audience, we have a audience from a wide range of departments. I like to give a background about bladder cancer. Bladder cancer broadly can be divided into two groups, and both of these groups have a varied prognosis, varied treatment, and completely different biology also. So the non-muscle invasive bladder cancer, which includes the TA, TIN carcinomas, C2 like Patna sir already mentioned in the previous presentation, constitutes about 70% of the bladder cancer. So it's a majority of the bladder cancer on presentation still are non-muscle invasive bladder cancer. The mainstay of treatment for these when they present to us is transurethral resection of bladder tumor with intravesical installation of BCG. So where did this BCG come from? TURBT has already been, tumor is out of the system. Why do we need a BCG? So BCG is basically one of the earliest form of immunotherapy. It is aimed once the tumor has been removed to reduce the recurrence and progression of the tumor. So that is the aim of BCG. But still, after giving a BCG, the recurrence rates range from 35 to 40%. Some studies have mentioned even the higher recurrence rate. 30%, 35% of the patients will die of bladder cancer, these patients who progress on BCG. In the literature available till date, the gold standard for BCG salvage has been radical cystectomy with bilateral pelvic lymphadenectomy. Only few agents till now, you can count it on your fingers, have been approved in the BCG salvage setting. So that's the background for the talk. Now, how do we define these BCG refractory cases? As I already told you, the gold standard for non-muscle invasive is TURBT via BCG, but still we get failures. So the first effort to classify these patients, how are they failing, was done in 2003. They were broadly classified into two groups, which were further in this article in 2006. They were then again reclassified into four groups. You can see on the screen BCG refractory, BCG resistant, BCG relapsing, and the BCG intolerant. So I'll start with the last one, which is quite easy to understand. BCG intolerant is basically any patient in which we have intravesical BCG after TURBT and they develop severe side effects to the BCG and not tolerating BCG. So these are basically patients not tolerating severe dysuria, LUTs, and they will not like to have this therapy again. They will curse you for giving this therapy. So then with the most dangerous one, the BCG refractory one. Inability to be disease free at 6 months after initial BCG treatment. Any progression in stage, grade or disease 3 months after the first cycle of BCG. Like already mentioned in the previous talks, we have the staging of pathological staging of bladder cancer, TA, TIS, T1. So T2 is muscle invasive, of course. So any progression while you are on BCG, your TURBT is done, the initial tumor was supposedly say TA, you started BCG. I'll just like to mention the schedule of BCG what we are following and which we followed world over is induction BCG and maintenance BCG. So induction BCG is basically 80 to 220 milligram of intravesical BCG, which is given weekly for 6 weeks. So this forms the induction BCG, and this is followed by a scopy, check cystoscopy, which we do in our in office at 3 months interval after starting the first dose of BCG. So if at that 3 months you find after TURBT that you have a tumor recurrence and you biopsy that, you do a TUR or a cold cup biopsy and you found that the tumor has increased in stage, progressed or has become T2 or supposedly has become T1 high grade, then it is called as progression of stage. So it is classified in this BCG refractory classification. So basically tumor has progressed. Now the BCG resistant, it is slightly less dangerous. As you can see the second line, failure is of less degree, stage grade, and absent on 6 months after BCG treatment. Supposedly you had a T1 tumor on the TURBT, the biopsy done at check cystoscopy at 3 months shows TA tumor. So it has not progressed, it is a tumor which is of lesser degree than the primary tumor, they will fall into BCG resistant. Then in the BCG relapsing, patient was given induction therapy, he was given maintenance therapy, and after that down the line during follow-up they developed a new tumor, they will fall into relapsing, early, intermediate or late. In the BCG intolerant I already explained. So this was a definition somewhere in 2006, around 17 years back. Then the question arises, in all this there was no mention about how much BCG has been given out of the total schedule. What is the adequate BCG? So in 2015 Genitourinary Cancer Symposium it was decided to clarify this issue and a definition for adequate BCG has been given. Like I already told you, BCG is a therapy which is associated with some significant side effects of dysuria, urinary tract symptoms. So some patients may not be able to take all the doses, and this leads to some patients getting only out supposedly 4 out of the 6 induction, or not the full maintenance course of the BCG. That's why this term came, who are the cohort of patients who got the adequate BCG. So now what is the rule is 5+2 rule. Out of the 6 induction courses, I already told you, he has received 5 intravesical BCG, and out of the 3 maintenance, they have received 2 maintenance minimum. Then only we can call the patient as adequate BCG exposed, and then we can classify him into the various classification I will be telling you. And this adequate BCG should happen within 6 months of the diagnosis of tumor. Any low grade recurrence, I already mentioned at 3 months we will do a check cystoscopy and see if there is any new tumor. Supposedly there is a tumor, I biopsy it, and it comes out to be a low grade tumor. So this is not considered a failure of BCG therapy. We take out the tumor, continue the BCG. Low grade tumor recurrences are not considered failures. The maintenance schedule which I mentioned to you, 6 induction, by then monthly, 3 weekly monthly, till 6, 12, 18, 24 and 36. That is a SWOG protocol, also called as LAMP protocol. So these were the definition. This is a paper which is showing the definitions of the new definitions: BCG refractory, BCG relapsing, and now BCG unresponsive. This word came out, BCG unresponsive. So basically BCG unresponsive is anything which is combination of BCG refractory and BCG relapsing. So what is BCG refractory then? BCG refractory is anything, I told you that 3 months we found a high grade tumor, which was, so any recurrence, any T1 recurrence, T1 high grade recurrence, at 3rd month of cystoscopy we biopsy it and find it that there is a T1 high grade recurrence, whatever the initial TACS, whatever it was, a T1 high grade recurrence at 3rd month is BCG failure, stat. There is no ifs and but after this. Supposedly the patient has a TA high grade recurrence at 3rd month, or supposedly he has a CIS recurrence after 3 months. Then we can continue the therapy either in the form of a reinduction BCG or a maintenance BCG. There are different school of thoughts, and continue that up to 6 months. If at 6 months he is still positive for that malignancy on a rebiopsy, that is BCG failure for them. Then what is BCG relapsing? Now the patient has completed induction, 6 weeks induction, plus a 3 weekly maintenance dose, and at 6 months we found that the patient has a tumor, adequate BCG after receiving, or during down the line he is found to have tumor, say as 12 months, after 6 months of adequate BCG, then it is called as BCG relapsing. This is from the paper, and this is the European Association of Urology. They describe it a little better. They have stratified into 3 categories. Like I already explained, if a T1 high grade or grade 3 tumor is present at 3rd month, that's the end of the story. He is BCG failure. If TA grade 3 tumor is present at 3rd month or at 6 months, either of a reduction or a maintenance, then it is a failure. If CIS is present at 3 months, you continue BCG till 6 months. The reason for that is it has been found in various studies that complete response in CIS patient after giving a maintenance BCG despite the tumor is 50%. So you can actually achieve response by adding BCG, not stop at maintenance BCG. Then we have the BCG relapsing. I already told you BCG unresponsive is now termed in which both BCG refractory and relapsing are clubbed together. Then there is BCG intolerant, patient who cannot tolerate BCG. So now, since now the issue is clear, what is the BCG refractoriness? What options do we have? Now the patient has failed. He is, as a surgeon, I have counseled him. You get a radical cystectomy done. He is not fit, maybe sometimes, and sometimes they want to preserve their. More and more patients are nowadays want to preserve their bladder, the natural, but of course, option for them. So what options we have? So this is a broad classification. Can be cytotoxic drug or novel approaches like ChatGPT. Novel approaches in this medical oncology are also coming up. I think they are the futures. Gene therapy, immunotherapy, vaccine, and oncolytic adenovirus, and the older chemotherapies. So some of these have been FDA approved. Like I told, very few therapies have been FDA approved, and the rest are part of clinical trials. So we'll one by one I'll just mention it, not bore you with the stats. So valrubicin was, I think, one of the earliest chemotherapy to be approved in BCG failed patients who have failed BCG. Although the response rate at 1 year was around 10%, I think 21% at 6 months, the response rate was not very good. So it led to search of newer molecules which can be intravesical. Then came the mitomycin, which was compared to even BCG. Response rate was okay, but not very good. Docetaxel also has been tried. Promising results were shown. 3-year recurrence-free survival 25, 1 year 48%. Varied result between different studies. Then came the idea to why don't we combine these two? If we try combination, gemcitabine was also there. It was compared with BCG. You can see in this survival curve there's a median recurrence-free survival of 13 months compared to 7 months of BCG. So there were like you can see light at the end of the tunnel, and then they led to combination therapies. Gemcitabine, docetaxel. So this has been, I think, a game changer mentioned in various medical oncology conferences. It has been tried, and we are also giving our patients who have BCG failed Gem-Dosi. The patients are now completing their therapy and coming up in next 2 years. A lot of patients are free of their tumors, and in studies also show the same response. High-grade recurrence-free survival to a tune of 65 to 52% respectively. The one issue with this is, which is not mentioned in the slide, is the rates are little poor for CIS. BCG, I told you the rates were good if we continue in the BCG failures. The 52% rate goes to 38% for this gemcitabine docetaxel combination. Then led the search to how we can increase the efficacy of intravesical therapy. We can try new therapies, how we can push more drug into the system. So it came delivery system, electromotive administration of mitomycin C. This is nothing but basically when you instill the drug intravesically, you want to create, normally the things will move into the bladder either through a concentration gradient. So here with the help of electroosmosis of ionophorosis, no rocket science term, but I basically are applying current and charging this particle to create an electric gradient against which this particle will move into the bladder. So mitomycin was tried with this EMD system, 61.5% high-grade disease-free survival at a median follow-up of 36 months. Not been approved, have been tried in various studies in clinical trials. Then radiofrequency induced thermotherapy, in which mitomycin was tried. This also relies on increasing the thermotherapy. Just I mentioned one thing about thermotherapy. It has been found, the idea is not very new, but it is like, I have read in books, it was around way back in 1866. It has been found that patients with sarcoma who were developing fever due to some viral illness, there was decrease in the size of sarcoma. So thermotherapy concept came from there. That if we increase the temperature, maybe the tumorigenesis or the immunity of a body to fighting the cancer increases, and that's why thermotherapy came. So basically in this, you are heating the mitomycin inside the bladder by radio frequency waves, and this is to increase temperature, and what they say is increase absorption of mitomycin, increase response. Other therapies, intravesical therapy, instead of heating inside the bladder, you are heating it outside, temperature of 41 to 43 degrees Celsius, 50% disease-free survival at 14 months. So all these things has been going up in clinical trials. A lot of centers in India are also offering this thermotherapy. Now coming to the gene-based therapy, the next thing which is happening and people are very excited about it is basically you are now programming the cells to fight against the cancer. How to do it? Insert them with a chip which can be in a form of adenovirus. So this fancy looking name, nadofaragene, I love this name, is you instill it with a gene, interferon alpha 2 beta, and ask this virus to enter the system, in which this molecule SYN3 helps. It basically opens the gag layers up. This interferon alpha 2 beta enters the cell, and then without changing your genome, it will ask your nucleus material to start producing more of interferon 2 alpha beta and fight the tumor. FDA approved in December 22. Very recently approved, marketed with the name of Elsteridine by Ferring Pharma. So promising treatment, intravesical coming up. This was the trial done phase 3 study in which every 3 monthly, month 1, month 4, month 7, 10 and 12, it was given and then continue up to 3 monthly. This was study design, and they found a very good response. Like one thing in this therapy which was very good and which I, as a surgeon, we are very happy about is that if a therapy has to be given, the response should be able to assess very soon whether this therapy will help or not. We should not be going for 1 year, 2 years and missing the golden opportunity in which we will miss the tumor to be turning to muscle invasive. Because we already know if the tumor turns muscle invasive, from an NMIBC, the survival at 5 years changes to 35% from 65%. So 30% fall. So this therapy, whatever response happens here in this study showed it happened in the initial 3 months. So we came to know about that the response rate is coming early or not, patient is not responding. So other gene-based therapy is CG0070, like James Bond. So Bond 03 trial is also going on, Core 01 trial is also going on, results are awaited. Maybe Dr. Akhil can update me if I am missing something. The results are awaited as of my knowledge. So this is basically targeting the RB pathway. We have all read in the Robbins that there is a P53 pathway, RB gene pathway. So this is basically targeting the RB gene pathway and asking the cell to produce more of granulocyte monocyte stimulating factor and asking to basically kill the tumor. So what are the guidelines? What is, after all this blah blah, what is happening? What are the guidelines? We work according to guidelines, what is happening? So basically NCCN and EEO guidelines, which most of us follow, BCG unresponsive in circle, cystectomy preferred, intravesical chemotherapy, pembrolizumab, I think Dr. Rahul Rai will be talking about it. The fancy name, nadofaragine, you can try that. So guidelines mention that. The Europeans say the definition of BCG unresponsive should be respected. It more precisely defines the patient who are unlikely to respond to BCG installation, correct? Often offer a RC to a patient with BCG unresponsive. And for those patients who are not responsive, I think should be a part of clinical trials. All this immunotherapy, hyperthermia can be given. Those patients who are desirous of saving their bladder, what is the trade-off? How long can that has to be seen in the coming results. So coming to the conclusions, BCG unresponsive disease, NMIBC is a high risk progression, has a high risk of progression and consequently cancer-related adverse events including death. Current guidelines from EAU, American Urological Association and other agency recommend a radical cystectomy as gold standard, but available study also report that if you are giving this therapy, the progression rate at 5% at 2 years. So the disease is slowly progressing, giving us some time to act before it actually turn MIBC and all these options come to a halt, unless and until patient wants a bladder preservation therapy, or trimodality, which I think will be discussed later on, leaving a decent window of opportunity for assessing newer conservative strategies in informed patient. Encourage the patient to participate in clinical trial unless he agrees to undergo a radical cystectomy, which must be offered as it is the only treatment to date that has proven effects on reducing the disease progression and death after BCG. However, if he refuses for a radical cystectomy or is not able to participate in clinical trials, then the current available data would use the support of combination chemotherapy, gemcitabine docetaxel, or hyperthermic chemotherapy. So this is one of the paper at the end of the nice paper I read yesterday only for preparing for this slide. Has case scenarios and nicely mentioned how should we go about these patients. Like for all our colleagues. Thank you and Bladder Cancer Awareness. Thank you.
Thank you. Thank you, Dr. Shashank. Carcinoma urinary bladder. We usually give the option of early or timely radical cystectomy to patient. So that option has definitely a survival advantage. Newer options are there. We can also try gemcitabine plus docetaxel. That is a vital option. This adenotherapy or gene therapy we are not using. That is in the trials. I am not sure is this available in data center. And one option I think radiotherapists can guide. There is also option of radiotherapy. If patient is wanting an option of radiotherapy in BCG and refractory carcinoma urinary bladder, if patient is not ready for radical cystectomy. So I think these are usually even high grade tumors are there. So radiotherapy is also a vital option along with chemotherapy.